This is the Health and Politics podcast, Prevention is the New Cure.
And that's with former ministers James Bethell and myself, Steve Brine. Hi, James.
Morning, Steve.
Nice to see you. Big episode today, James. Big interview. We have Sir Jim Mackey coming on, who heads the NHS. Big senior figure in national health leadership, of course. More on that in a moment.
I'm quite nervous.
Are you?
Yeah. It's a big deal.
What are we going to cover with him? Give us a teaser.
Well, I want to talk to him really about prevention and hold his feet to the fire a bit. But there are other things going on.
There is loads going on. Anyway, what have you been up to? I hear you were at supper last night. Interesting topic.
Steve, I had a most remarkable supper last night. I'm a fellow of the Milken Institute, which I find an amazing global network that leans in on prevention in particular. Mike Milken has been on that beat for 30 years. And it's also a nexus where health and business meet, which is a really important point to be in. And they've launched a women's health network chaired by Dr. Jill Biden of White House fame, who's a famous women's health leader, as well as everything else that's gone on in her life. And we had a complete sellout, 30 people in my house, which is more than I can really handle. And the vibe was extraordinary, Steve. You don't get, this is not just me being a good host or the Milken being an attractive group or Jill on her own being astonishing, although she is. There's clearly something catalytic going on this agenda. There was such a meeting of thoughtfulness and energy and ambition in the room. And this wasn't the normal special pleading by a niche group. This was thoughtful, well-informed, ambitious change makers who were clearly talking to each other and trying to address this massive gap we have in our health system, which is we've designed it around a 40-year-old white male, and that's left half the country out of the model. So really, I mean, watch this space. I think women's health is such a big force for change at the moment.
I've got an interesting guest, hopefully coming up on that in a few weeks' time. But what did you serve for dinner, out of interest? I just want to see what culinary Bethell.
Yeah, it wasn't. I didn't serve roast beef and the usual.
Right.
No, I had a very good ratatouille from Ottolenghi, a salsify puree, and a fennel salad, and pea soup. So in other words, no lactose, hardly any carbs, and really healthy, nutritious food.
Was so West London.
I know.
Anyway, look, thanks for finding this podcast. This is where we talk all things health and politics. It's called Prevention is the New Cure. This is episode 84. Before we bring in our special guest today, James, look, we would be crazy in a health and politics podcast not to touch on what has been an incredible political week, and it's only Wednesday as we record this. Huge political crisis swirling around the Labour government, around Keir Starmer, obviously the fallout from Mandelson and the Epstein files. I just sort of thought we'd touch on just for a minute here that when a political crisis is swirling around the government and around the ministers, how that impacts in a big spending department as we used to be ministers in, because it is hugely distracting, isn't it? I just wonder, what are you hearing in and around Westminster?
Well, people in health are very distracted. It's the short answer.
Yeah.
Someone told me that they'd written a big report that had been requested by number 10, and it was all ready to go, and they decided just to sit on it for 10 days because they weren't quite sure exactly who was going to be in number 10, so no point sending it in. That joking aside, that is very paralysing. If you have collectively a whole senior cadre of decision makers who are sitting on key moments because they're anxious about what might happen, the whole thing turns to treacle. And I think what's troubling about this is it's not just about the personalities. There's a fight at the heart of the Labour Party about which direction they're going to go in. If they dump the Blairites and lurch left and it becomes all very Ed Miliband, that will have a huge bearing on health. And we should discuss that. I won't go. So it's not just people, it's positioning and mission. That's what's at stake.
Yeah, I agree. I mean, last week, listeners will know we had Professor Peter Johnson on, who obviously is one of the authors of the National Cancer Plan, which was launched on a massive political news day. Didn't get anything like, West Street on the Today programme, 10-minute interview, probably talked for the cancer plan for about 1 minute.
Yep.
And, I've done a number of events since that talking about the cancer plan, including one yesterday, actually, a round table where Peter was also part of it. And I suppose a lot of it, you consider how invested Wes Streeting as a cancer survivor is, and the cancer minister herself is very invested in this subject. But of course, they won't always be there.
Yeah.
And if you think about the last few days, Wes Streeting publishing his WhatsApp messages with Peter Mandelson, special cabinet meetings of the PLP. Do we think the health secretary has been convening meetings about how we're going to meet the 75% target that we've just put out there on cancer? No, of course not. They're distracted by the politics. I mean, 'twas ever so. And, you could say, well, a couple of former Conservative ministers have got a nerve discussing this. But, in a way, we discuss it from a position of experience and with the scars on our back, don't we? Another subject, James, CQC. I don't know whether you spotted this during the week, but Sir Mike Richards, who you and I both worked with in the department, has decided to step down as chair of CQC. Another big figure in the UK health scene. And I just read you this line from the statement that he put out. We've made progress on several critical improvements. I'm particularly pleased we've now specialist sector teams. However, it's become increasingly clear the turnaround of the CQC, alongside the work required to establish it as the world's leading health and care regulator, will demand a longer-term commitment of chair than I'm able to make. Now, of course, this follows Sir Julian Hartley's resignation as the chief executive of CQC, pending the maternity investigation in Leeds, where he was chief executive for many, many years. So it's a rudderless organisation, and this should worry us from a prevention point of view and a patient safety point of view.
It worries the hell out of me. I spoke to Mike at the end of last year. He was really fired up about this role. He had a clear plan. He was very ambitious. He had a whole turnaround mojo going on. I was really surprised. Steve, I've got to admit, I don't really know what's going on. I sense meltdown, and you're right. CQC is one of the cornerstone institutions of our health system. The fact that it's troubled means there's probably issues elsewhere. And if it's not fixed soon, other things will go wrong, and we will start having hospital scandals. We'll start having breakdowns in confidence, and it's all going to hit trust and productivity in the NHS. So, this is bad news. I hope someone somewhere grips it soon.
Tell you what I think, I'll have a stab at what I think is going on, is that I don't think the CQC feels that it enjoys the support in its current form from ministers. Right. I was surprised, actually, following the Dash review. Penny Dash, who's now the chair of NHS England, of course, did this big review into patient safety last year. I was surprised it didn't recommend fundamental reforming, rebranding, reshaping of the CQC, complete renaming it into a different organisation. I wonder whether there was that tension in government as to whether it should say that. It didn't come down to that, but that theory persists. And, Mike Richards, obviously the first chief inspector of hospitals, the perfect choice to be the chair of it. Now, okay, Mike is, I think he wouldn't mind us saying, he's probably on the back nine, as they say, of your career. So he probably feels it's a longer term job than he can do. And it could just be that from his point of view. But, I would like to see it completely reshaped into an organisation that focuses on patient safety, productivity, value for money, and how we prevent ill health. And that's no small change alongside, reorganisation of NHS England, cancer plan, 10-year workforce plan, the 10-year plan, and all those things. But, hey, government, you've got to chew gum and walk at the same time, right?
Yeah.
Anyway, you want to talk about health checks?
Health checks. Steve, I'm very passionate about health checks. And they are the intervention when we hit our 40s that is going to help us change our behaviours and prioritise different parts of our health. For me personally, it was a big intervention. I did one when I became appointed minister. John Bell marched me figuratively to my local GP, and I met with a nurse who I've seen 3 or 4 times since, and she did a great job and explained to me what I needed to do, and I got on and did it, and I'm in better shape for it. GPs have never loved them. They feel that they're not paid enough for them, that it's distracting, that the insights aren't necessarily have clinical value, that the behaviour change from patients doesn't materialise. I have some sympathy for every single one of those points. But wow, if we're going to pivot to prevention, if we're really going to try to head off disease, this is the absolute key intervention we need. And a Pulse survey revealed that GPs are deeply divided, i.e. most of them are pretty sceptical, on the clinical value of health checks, especially given current pressures in general practice. And some of them do think of it as crucial prevention, but a lot of them think of it as a box ticking exercise that diverts resources from sicker patients. Wow, that is a devastating assessment of a scheme that's been around for 10 years. And instead of doubling down on it and expanding it, that's the sort of signal that a lot of people want to back off it. This is not good. If you mark the homework of the NHS on the shift left, this is a sign that we're going backwards, not forwards. So I'm really worried about that.
Goes to the heart, as we say, doesn't it, of the prevention agenda? Because, population level health checks, they are genuinely about preventing disease, picking up high blood pressure, undiagnosed, and all other things. And of course, they exist and have existed for years at great scale in the independent sector. And of course, many people now, through their work, access to private healthcare, general practice privately, and annual health checks. Where that join up is between the independent sector health checks and the NHS, and then bringing that all together in the single patient record, for me, is kind of the crux of this. Because unless that happens, you can see why GPs feel that, a bit like, well, the patients are going here, there, and everywhere. I've got lots of people coming in the front door. We've now got an always-on computer where people are sending in messages all the time virtually. And, what do you want us to do? Which is sort of what the GPs will say. And that's, of course, why Pulse, who GP publication have put this out there. But when I turned 40, I obviously should have been invited for a health check. I was an MP at the time. I think it was probably some 2.5 years into my 40s before I was invited for a health check. So, when it comes to population list management, as they used to call it in general practice, something ain't working, is it?
I know. No, it doesn't. But you've also got to wonder, why do the rich live longer and healthier than the poor? Partly it's the determinants of health and environments, but partly it's because they intervene earlier. And as you said, their insurance companies and their cash in hand pay for health checks in the 30s and 40s, which mean that they then take the medicines, the treatments, and the behavior changes necessary to lead a healthier life. It is devastating for the system to think that we might just not have enough resources to do this very, very basic intervention. We don't know how much 90% of the country weigh or what their blood pressure is. The idea that the NHS has got this amazing database of everyone's health, that's true of people carrying significant disease who are in and out of hospital. But for the most of the population, we're completely flying blind. We see them when women have a baby. But this is the one time when you can try to catch everyone and spell out the absolute bleeding obvious. You need to lose some weight. You need to give up some smoking. We need to get you in and scan your heart, your lungs, your whatever. If you don't do that, we may as well jack in the prevention agenda altogether.
Yeah, I think far too many people feel that basically it's up to them to juggle all these balls, to manage all these projects. And if they don't, no one will. Now, today's daily quiz question, James. Steve, question to James. Why am I saying Mr. Beast to you?
Steve, you didn't know who Mr. Beast was, which was a huge...
No, I did. No, my son is a huge fan of the Beast.
I know. So you asked your son.
He loves the Beast.
I know.
Yes, I did have to ask the son. Yes, tell me.
Mr. Beast is absolutely the most consequential celebrity in the world today. And he's just an extraordinary phenomenon who started in his bedroom on a YouTube channel and built this incredible following by doing games and stunts and hilariousness and working hard with sponsors, making a ton of money on the way. But he's a fun guy and they come up with great things. I mean, it's very compulsive. One thing he did was to line up a person from every year of age from 1 to 100. So 100 people. First one, I think it started at 15 or something, 1 to 100, and made them race over 50 yards. And there's a beautiful diagram that shows the spread of people. And obviously at 100, they're moving quite slowly. And at 5 or 10, they're moving quite slowly. And 20 or 30 is the cluster that's nearest the line. But within each decade, there's a huge variance. There are 22-year-olds who are dashing for the line. And there are 23-year-olds who are not moving as fast as the fastest 70-year-olds. And it's just such a powerful image for how we can curate our life our health. If we're blessed with the opportunity, you really can be in better shape in your 60s and 70s than many people are in their 20s and 30s. And I looked at that picture and I just thought, I know what I want to be. I want to be the person in their 70s dashing for the line, beating the 30-year-olds. That's my mission in life.
You put it on your LinkedIn page, so we will share it onto the show channel. So he's got Jimmy Donaldson. That's his real name. The Jimmy is Mr. Beast. How many subscribers do you reckon he has on YouTube,
God.
James? It's a few more than us.
I think it's like 100 million or something, isn't it?
400 million.
My God.
He's got 190 million followers on TikTok. So yeah, he's got a reasonable following as the Beast. My son, slightly more flippantly than your worthy one that you used to watch him do things like hit a golf ball off the top of a building and try and get it into a bin and things like that. Don't try that at home. Very dangerous. Anyway, who knew? Health checks to Mr. Beast to the CQC. Right, we will take a quick break. Just to say before we do though, James, if you want to get in touch with us, prevention is the new cure podcast at gmail.com. And we also have a WhatsApp number. Who knew? 0333 404 6507. You can WhatsApp us your questions and feedback, including on the interview with Jim Mackey, and that comes next. Welcome back. This is the Prevention is the New Cure, the Health and Politics podcast with myself, Steve Brine, and James Bethell. As you're listening or watching, press subscribe to get our brand new episodes every week. You can WhatsApp us now as you're listening with questions, comments. Ideally, send us a voice note and then we can play it in on the next episode. The WhatsApp number is 0333 404 6507. Now, Sir Jim Mackey joined the NHS in 1990. It's the year I left school, Jim. He's held finance director roles. He made his name as one of the doers of chief executive of the Northumbria Healthcare NHS Foundation Trust, and then chief executive of NHS England, which is where we first met each other in Jeremy Hunt's famous Monday morning meetings at the Department of Health. He was appointed in September 2021 to lead NHS England's efforts to reduce the backlog in elective services following the COVID-19 pandemic. And more recently, he's been CEO of the Newcastle upon Tyne NHS Trust, after which, the big one, he became the interim CEO of NHS England on April the 1st last year, following Amanda Pritchard's resignation, with the curious title, Transition Chief Executive. Welcome, Jim Mackey, to Prevention is the New Cure.
Hi, Steve. Hi, James. Nice to see you.
Jim, really good to see you. Jim, you're an enormously popular appointment. When we ask around, everyone is thrilled that you're the person in that seat. And that's partly because of the reputation of what you did in the Northeast, which has been a huge achievement. And it was done a lot through ruthless focus on hospital productivity and efficiency, getting the waiting list down, throughput up, performance managed relentlessly. But now you're on the prevention podcast. So the prevention guys want to ask you, how are you the person to put prevention at the heart, which is at the heart of the 10-year plan? How are you going to be putting that into practice? And how does upstream intervention fit into your worldview on a personal basis? Because we hadn't heard a lot of it from you previously. So I'd like to hear straight from you your sentiments.
Yeah, that's great, and thanks for the kind words as well, there, James. So you do feel, as you understand, you get kind of caricatured in certain ways when you're doing these national rules, and a lot of what we're having to do and have been doing over the last year around the financial reset has been around hospital productivity, the waiting list reduction, managing industrial action, etc. But the 10-year plan sets out a different game for the NHS to play, which again we've been in and out of over the years, but this is hopefully a more sustained effort on shifting patterns of care, shifting the balance more out of hospital, further upstream, more technologized, those sorts of things, because our system's got out of balance. If we compare where we are now in terms of proportion of spend in hospital versus community, primary care, prevention, it's very distorted compared to what it was 10 years ago. And it's also very distorted if you look at other systems that we have a high regard for. So there's no, I don't think there's any doubt that we need to do that, first of all, but we are in a natural phase of lots of hospital, heavy lifting, cost reduction, productivity management, those sorts of things. My life in Northumbria though was very different to that, really, because we were very whole system. We used to talk about whole system a lot in the early days.
Yeah.
It was an organisation that ran hospital services, was the biggest part of its expenditure and staffing, also ran community service for most of the time that I was involved, had a primary care business that ran lots of GP practices, and for over 10 years was responsible for social care for one of our councils through a partnership agreement. I think I spent probably more than half of my time working on things that weren't hospital orientated, because it was very much about community, about our place in the community, working with primary care, working with both councils actively about identifying people we should be worrying about, trying to get more upstream. Northumbria created a public health function within the organisation really, really early doors to work with both councils and the broader system on that. So, and when we're talking about neighbourhoods now, I get a lot of grief about I'm saying this and saying this from a hospital perspective, and that's just not true. Neighbourhoods are about all partner play, every part of the system working together in manageable communities, usually at that level. It's quite easy through the analytical methods we've got, but also just the visibility of who people will see across the service to work on together.
Can I press you on that point? Because you're definitely saying the right things from a process point of view.
Yeah.
But I just want to hear it a little bit more personally. Working in communities, it does mean we're going to have smaller hospitals. Page 28 of the 10-year plan does specifically say taking money off hospitals and putting them into the community. So some people in hospitals will need to not do their jobs there anymore.
Yeah.
And a different type of workforce will need to be recruited on quite a large scale to deliver it.
Yeah.
Possibly with infrastructure bill, but I mean, that is a completely different way of doing things. How do you sentimentally, I mean, how do you feel about that? And how do you think about, where do you think we're going to be in 2 or 3 years' time? And I'd like to press you on the local authorities point. Are you really going to put together meaningful partnerships with the other institutions on the ground, like the local authorities?
Yeah, great question. So first of all, as I've said before, being in and out of this in my whole career, like lots of times over the years, we've generally either lost interest, focus, it's got deprioritized, or we couldn't make the money work. But the common thread is it's the right thing to do. You will not meet a hospital leader who will say that they're worried about losing work and patients. It's just, everyone's got more patients and work than they can cope with. What they're worried about is the money shifts, but the patients don't, which is what's happened before. So there's been investment in things that didn't actually prevent flow in hospital, or not do it in a significant enough way within the financial parameters for it to be felt to have made a difference in the hospital service, and therefore they're still left with a big burden and a financial burden, etc., and patients not getting what they need. We've done various things already, and we'll continue to do this, about the unbundling of the block contract in a hospital service, which then unlocks the money to allow us to be able to say, well, if you can invest out there, and that stops the ICB having to fund the hospital service for that, great. Just make the maths work, and that's great. And when we go through this year, and we'll be doing this again soon, we'll be asking for plans from neighbourhood teams to say, what is it you want to make an impact on? We've got some fixed things that we want to improve around access to primary care, probably around frailty, a couple of the shifting outpatients. If you want the outpatient budget, talk to us about it. If you can find a new way of delivering that more locally, with less people travelling up the hospital, great. Let's just see how the maths works. Similarly, shows the business case on what you'll do around the frail, population. Convince yourselves and us you can do things in community to stop people being churned through the hospital system. I honestly think if we can do that, the biggest relief will be in the hospital sector, because everybody's just absolutely stowed out with patients. And also, we've all seen and experienced what that means for old people, especially being churned through a machine that isn't built necessarily to look after complexity, and it's not the right place for them, so so I think there's complete agreement on all of that. Next point, we are grappling with, in all of our work, how do we get the balance right between giving a strong enough signal but not telling everybody what explicitly they should do, because we've had a bit of a period of that. So we're trying to allow people some local room for flexibility. At the local authority interface, I trained in local government. I've got mates who still work in local government. One of the things they really hate is the NHS telling them what to do. So again, this really only works in the end with joint teams, fully integrated teams at a neighbourhood level, where they're jointly led using shared analytical resource, single leadership, ideally over time. Probably have to be entities over time where they can hold assets, they can build things, they can hold contracts, they can employ people. We're just not in that place yet, but we'll start moving rapidly into that place. And I know, talking to colleagues around the country, that's happening. If anyone in the NHS says they're doing that, and then they'll talk to the councils in 3 or 4 years' time, we'll miss the point. Everybody's got to be in at the beginning. I did a session a couple of weeks ago where I was a bit surprised about the push from that system about their desire to have the health and justice system in at the beginning, because they thought it was a big problem for them. Their data and their experience was that was a big problem for them. That's absolutely fine. Other places that would be housing would be right in at the beginning as well. But the very obvious things are hospital, community services, primary care, mental health, social care have to be welded together. And in my Northumbria experience, at least for large parts of it, you could apply the test, which I would say, where you watch from a window in a room of a team working together. You shouldn't be able to tell who's working for who, because they're working for the neighbourhood, they're working for the population. It sounds really twee, but at its best, it is that. People can then be employed by different entities, but they're working to a single purpose and a single common sort of spirit and way of working, and those sorts of things. So I think that's really what it's about. And we'll have to see how the year goes on to see whether the pace at which this is moving, because it is moving on the ground. In a national system, you can quickly convince yourself nothing's happening, so you have to keep checking and go and seeing real people to see what's actually happening. But this feel really different place to place, and there's a degree to which it has to be, but there also has to be a common thread throughout. And then I would expect us to hit obstacles where the system comes back to us and say, actually, we do need an organisational form, or we do need a specific kind of contract, or we need these financial mechanisms to support us further in what we're doing. And we're absolutely up for that.
Jim, sort of linked to that in a way, I saw you at a Tech UK conference back end of last year. And you said if we carry on doing things the same in the NHS, GP appointment, a letter, an outpatient's appointment, the NHS is done. They were your words. What did you mean by that? And is it your view the same is true of real prevention, i.e. finally addressing the demand-supply dynamic? What did you mean by the NHS is done if we carry on doing things the same way?
So as I said, we've had this massive growth in workforce. We've spent a lot of money already on technology. Every part of our system describes being overwhelmed with work, and you hear people talk about burnout and all those sorts of things that are really being felt by people. But you stand back from it and you think we've had this massive investment, big growth in people, seeing slightly more than we were pre-COVID. There's something going on there. First point, we have to lean into that and work that out and work our way through it. But we're also still largely working with a set of archetypes, organizational models and systems that were built in 48. Some of them built 200 years ago. The way we run outpatients now has barely changed over a few hundred years. In reality, people live their lives differently now, but it's also very sequential. It's we'll do this bit, we'll communicate with this bit, they'll do this, then someone will come back. From the patient's point of view, there's an awful lot of repetition. And I think we're all intolerant of that more now because we don't live our other lives like that. So there's a bit of consumer change there that's necessary for us to lean into. It's also, it feels like it's set up for our convenience because we're putting people into queues that we can manage. And I just think that's fundamentally wrong. I think the customer, the patient, or the patient's families or advocates should have more choice in how all that works. I think then once we can get into that place and in the tech context, it is more about them owning their tech and us having access to it rather than us having spent a fortune on APRs and managing their care through it. I think that's quite a big psychological shift. But
Yeah, no,
then
that
the
makes
easiest,
sense.
and the thing we're
And on,
compared to all the time is banking and the way that banking has changed. This is more complicated and there's different, yeah, risks involved and stuff. But I think it is a better example of kind of get your head around how the patient will own all of this. They will then tell us, don't keep asking me that. I don't want to go through all these steps. I just want to go to there. I want to have a bit of an interaction to get us unlocked from that system that we've had for decades and longer.
yeah, and I mean, like, the NHS, if the Amazon app logged me out as many times as the NHS app does,
Yeah.
I would not use the Amazon app.
Yeah.
It's as simple as that. Is your view that if we carry on doing things the way that we are and demand continues to outstrip supply, is the NHS in big trouble? I mean, that's
Yeah,
the whole basis of this
I think,
podcast, which is prevention is
yeah,
better than cure.
I think that's right. And I think we all, that's part of why I'm here. And I think that's part of the leadership response over this year that I think everyone agrees that we can't just try to keep getting better at playing this game. We have to find a different game that's just more rational. It's more productive. It's better for our patients. It's more enjoyable for our staff. It's more possible for our staff to do what they were trained to do. And again, and I can't think of any other part of my life, or I'm sure you can't either, where you're still trying to do exactly what you were doing in the 70s or in the 60s or, whatever, in
Yeah.
exactly the same way. It still feels like the NHS is still trying to do that. But when you can get your head around actually, and this is happening. We had a chief execs event a few weeks ago where we shared some examples where organizations that said, I can do the whole, I'll improve by 0.5% on this and 5% on that and
Yeah.
2% on this over time. Then we all get there in 2056 or whatever. Or
Yeah.
we can tear it up. We do the thing that all the modeling says isn't possible. We reduce the waiting list by 25% in a year. We improve RTT performance by 10% in 10 months. We will go from 60% on 4 hours to 75% in a couple of weeks because we've just changed the game. And I think there's quite a lot of that going on. And in prevention is, and we haven't touched much yet on prevention, but is one of those areas where again feels like the NHS says I can do all these things, but not them. I can look after hospitals, but not community. We can do prevention, but it means people have to wait longer in A&E. I don't
Yeah.
accept that's true. I think we have to do all of them. And the thing that really helps from a prevention point of view is in hospital, it costs roughly £3.5 million to open a ward. And
Mm.
if I was still in the trust and I opened a ward this morning, it would be full by the time I go home tonight. You get almost no value immediately from it. Everything just eases out. You spend £3.5 million in Newcastle or in Northumbria that I know well on prevention. You couldn't actually digest it. The service could not find things on prevention to spend money on at that level. So there's a financial gearing we can bring to this. That means we can make proportionately massive impact in prevention using the evidence. And again, it's something that there's just really fantastically strong evidence over the years of things that work. But we've
Yeah, we
struggled to
got
give it
lots
the
of them. Yeah.
headspace.
So just finally then, Jim, you're Jim Mackey, the disruptor. That's what you're
Mhm.
saying. You're saying you're
Yeah.
a disruptor.
Yeah, and I think I've kind of accidentally ended up being a disruptor through my career, I think, because I just hate being locked into a paradigm that means you can't deliver what you need to do. And now we have got loads of them across this, loads of colleagues around the service that are doing this, clinical managerial colleagues who are trying to tear things up and disrupt. And to get where we want to be, which is the world's best health and care system. Again, that's the way out of it. And it's not, so if that is disruption, I am that, that's what I'm
Very good. James.
really up for.
Jim, can I put you on the spot then and ask you about a specific item?
Yeah.
GP health checks, they have been around for a long time. There is a large amount of validated research about their value.
Yeah.
But we know GPs don't like them. There was a
Mhm.
Pulse survey last week, you may have seen it, that spelt out in clear terms the ambivalence. Some, a minority, see them as crucial, but a
Mhm.
lot think of them as a box-ticking exercise, a
Yeah.
waste of scarce appointments, and are just targeted at the wrong people instead of the sick people. Now,
Yeah.
if you're trying to do a pivot from acute to prevention, the health check's got to be, I mean, I don't need to rehearse the arguments for you. It's got to be one of your building blocks going through. So if the GPs really don't want to do it, however much we pay them, however much we try to value it and support it, and
Mm.
is there another way of doing? I mean, what's your view on that? Do you think we just need to re-engage GPs and try once again to show how committed we are to this program? Do we need to take it off GPs and give it to
Yeah.
pharmacists, or bring private sector support in? I mean, where's your ambition here? How disruptive are
Yeah.
you prepared to be, and what kind of message are you trying to deliver to primary care about
Yeah.
its potential role in the prevention revolution?
Another great question. So there's a couple of things immediately come to mind. I'm talking to a bunch of GPs tomorrow. There'll be 100 or so GPs that we're talking about exactly this issue and the future of primary care and leadership of primary care, etc. And we did a public accounts committee the other day, which was one of the topics was frailty. Haven't done one
Yeah,
a few weeks ago on hospices.
Lucky you.
Yeah,
yeah,
in that, in the prep, there's a good NEO report that basically said the things that work in frailty are no longer being done in primary care, haven't been done in primary care,
right.
and I think that's true. The evidence is pretty clear that hasn't been being done in a systematic way over recent years. And you can look at other things. And talking to colleagues on the way out, I was a bit frustrated because it was a report from a couple of years ago, and it is annoying that those things weren't getting done. But at the time, the main focus was on urgent access, and money was tight, and there was a GP shortage, and et cetera, et cetera. So we have to get into a space where we're looking in the round to say there are all these things that could and should be done in primary care and or in a neighbourhood. What's a sense of priority? How do we get that right? And the priority for our patients is the main thing, but also how do we support that nationally? And then there is a factor in there about what does that mean if you're a GP working in it? Does that mean you're spending all your life doing stuff that you don't want to do? It's not the thing that brings you joy in your work. And so we've got to reconcile all these things and get the balance right. I don't think we've had the balance right on that first point. Second thing is the neighbourhood system is completely multidisciplinary as I see it. So I actually still have a health check. So my practice still does it. I had one before Christmas, and I'm of an age where I'm starting to get things that I don't want to get. And
Yeah,
so I've been having a bit of a tussle with my GP about I'm going to have to confront a couple of things. And
yeah. Tell me about
yeah,
it.
and it's not pleasant, is it? But it's a good system, all delivered initially fantastically well by a nurse, where she was the person who I saw. She did
Yep.
all the tests. We had a phone call afterwards. And then the hard bit now is my GP needs to get me over the to persuade me to start taking a medication that I don't want to take. And so I think this does work in places. It's absolutely nowhere as near as structured and as organized and as consistent as it needs to be, top to bottom.
Can I just press you on
Yeah,
that? There's quite a lot of things that you don't even need to talk to a GP about. I mean,
yeah,
really, that is a redundant conversation.
yeah,
And I know I also dealt with a nurse who was excellent. I still speak to her. But I had to go to my GP surgery in order to see the nurse, and
yeah,
with the inevitable. I also have a pharmacist. I also have a gym around the corner. Quite a lot of it
yeah,
could have been done in the gym. We're not going to. We're at about 43% reach at the moment on
yeah.
health check. Quite a lot of people many years late. We're not going to get that up to, I don't know, 95% would be good if we just try to push harder on the current model.
No,
I'm not trying to. It's not the health check. I want to get
no.
a sense of the scale of your ambition and how
Yes.
how
So
far
I
you're
think that
prepared to
does
go.
go back to that. The neighbourhood thing is a disruptor thing, as Steve said, and that would be about in that manageable population, people working together, looking at their resource that they've got, and you described the voluntary sector included, whether they've got access to gyms, the pharmacies, all the things that you've described, and then everyone working together and working out their workload, their offer, their system, so it's clear to the population about who gets what, risk stratifying it appropriately, and making sure they're proactively managing the parts of the population that they should be. Um, there's just so much in that needs a reassembling of the bricks. So that's the thing. And getting back to the one of the earlier points, the test for us is whether we can reassemble the bricks in a way quickly enough that we can really shift health properly, and whether it can really shift public satisfaction properly. And Steve knows I'm an optimist and all these things. I think we can. I think we can see things moving out there. But there is a desire nationally to want everyone to move at the same pace. So you can see everybody in the country moves really rapidly. It's just not possible. Everyone's in a different position. The needs are different. Their infrastructure is different. But we'll give a strong enough signal on these are the things that are important. But on your point, it's not about delivering the old world better. It's delivering a new world. It sounds really ridiculous, doesn't it? But I just think that's the way. I think that's the way out of
Yeah.
it. And then
But
we
you
again,
are,
just very finally on that. I do think the engagement with the population will flush out more of the. I really don't want that. I'm quite happy with this. Why on earth are you doing that? Um, and if we can somehow instill a bit of your point, Steve, on the Amazon thing, why are people tolerating that? They're tolerating it because we're not currently giving them the choice. We're not
yeah,
listening
you don't have
to
any
them
choice.
properly.
I
Yeah,
don't have another NHS out. Just in the time we got left, Jim, just sort of some quick fire stuff. You are an optimist. Some suggestion this week of movement in the long running, very bitter dispute between the BMA and the government over resident doctors. Story in the Guardian a couple of days ago said that Wes Streeting's going to offer them bigger pay rise, but also package of measures which says hospitals will be fined if they don't give doctors good working conditions such as rest areas and access to hot food. So, does your optimism spread to the resident doctors? Could there be an end in sight?
yeah. So straining the politics a little bit, which I'll keep out of. But
Yeah,
what
sure. But it's without the resident
what
doctor workforce, you're in trouble.
we want all of our workforce to love being in the NHS and love working for the NHS as well. We created this 10-point plan last year about improving the working lives of doctors, and honestly, a lot of it was just really obvious stuff that the NHS has been tolerating for a long time. But as colleagues rightly keep reminding me, the rest of the workforce have lots of things that they've had to tolerate for a long time. It's not about, I don't think it's about more numbers. I think a lot of it's environmental friction, the food, the parking,
Yeah.
whether you can safely park your bike without it getting stolen, whether you're in a ward where there's a leak through the roof, all those things, and and having a sense of belonging and feeling respected by your organization, by your colleagues, and by the community. And they're all really strong things we need to get back to. We're just about to start recruitment for a national rule around patient experience and starting to systemize that. And I want us to do a similar thing in terms of elevating staff experience. So we can start actually leaning in again to an NHS that actually looks after people properly, but we expect things in return. We need people to perform well. We need people to perform to decent standards consistently. We've got to be productive in what we do. So there's going to have to be a bit of a reset of a deal and all of that.
Okay, so the journalist in me just got to push you. They've had 14 strikes. If you
Yeah.
were a betting man, will they have a 15th? The residents.
Well, I've never ever laid a bet in my life, and I hope never to.
All right, all right. Diplomatic.
Recent discussions have been very constructive, but there's a lot to get through in terms of avoidance.
Right. Another quick one. As we record, there's a maternity safety rally taking place in Westminster today, Wednesday. They're calling for the appointment of a dedicated maternity commissioner in the UK.
Yeah.
You'll obviously be aware Baroness Amos is doing this work at the moment, the maternity safety review. Are you aware campaign for a maternity commissioner. How serious is NHS England taking what is a all too familiar pattern of avoidable harm? This is
Yeah.
classic prevention, isn't it? At the very, very start of life. Are you aware of that campaign being led by former colleague of mine in the House of Commons, Theo Clark?
I am aware of the campaign. I talked to my wife and daughters about this a couple of weeks ago, and I saw a bit on the television about it all. So we're all very worried about what's been going on in maternity care. We've had lots and lots and lots of reviews, so we've created a very complex landscape. My view would be let's let Baroness Amos do her work and then go from there, rather than adding any more complexity into the system. Now, and I know from the time in Northumbria and then especially in Newcastle, I remember a board day where we spent most of the day talking about various external interpretations of our maternity service. And honestly, at the end of it, I was bewildered. I felt I didn't know whether we were running a good service, a bad service. I knew from my own data and intelligence and talking to the staff and patients and stuff what was going on. But at the end, the board would have been incredibly confused about what the position was. So I think there's a desire to lean into this and fix it, but it has become very, very complicated, and we need to avoid more complexity in it.
Okay, one more quick one. Community pharmacy, former
Yeah,
pharmacy minister. I'm very passionate about it. You put it very much at the heart of the 10-year plan as part of the hospital to community shift. Pharmacy
yeah.
first, been a good success. I know you want to build on it. But they're being hit by the rising costs of being a private business, rises in
Mm.
utilities, wages, of course, business rates. They've not been subject to the rebate that the government have given to pubs, for instance, on business rates. Do you think you can achieve the step change that you want in the hospitals community shift, especially without a step change in funding for community pharmacy?
Again, I mean, I think this is really a casualty of the pressure on the money overall, Steve. And at the minute, there isn't an easy way of saying we can put more money into that without taking it from somewhere else. That's very important. We'll have to find a way of resolving the matter, and I do believe strongly in we need a vibrant community pharmacy system to support all of the things that we've just talked about. But we haven't yet got a solution. It's being actively discussed, and we're going to have to find a way through. And again, just before I started on this role, we were having discussions with a couple in the trust, a couple of community pharmacies about whether the trust actually went into that business and started supporting local community pharmacies in a different way because it was so important to us. So we have to find a plan. We haven't got a very clear path to resolving the matter yet, and that's largely financial. We're gonna
Right.
have
Okay, couple more questions. One from James and then one from me about the future.
yeah.
Um, Jim, can I just ask you about the political situation? Uh, we've both been ministers. We know what it's like. I was minister during a particularly complicated time.
Mhm.
How do you, as a leader, explain and manage your colleagues at a time when they're seeing, potentially a change in prime minister, change in health secretary? I don't know what's going to happen, but it's definitely. How do you stop the system seizing up? How do you
Mm.
stop people from worrying and focusing on their day job?
Yeah, so I mean, for understandable reasons, this is a thing in the service at the minute, and we've had far too much churn over recent years. And so, first of all, is the service actually quite used to it and gets used to it. Um, the main thing is, and hopefully we're not going to have any churn. We've got a good team currently. We work well together. There's very strong alignment on purpose and stuff. Um, we've got to focus on what we've got to focus on. We've got a huge delivery task to deliver on. In a national system, we be really ruthless in focusing on what we've set out to deliver. And in all of our communication within the system throughout the NHS will be about that. Ignore the politics. We've got a 10-year plan. We've set out a set of performance and financial imperatives. We know what we want to do on public satisfaction, etc. Let's stay focused on all that. At a local level, honestly, you take almost no notice of it. Yeah, and generally the way hospital leaders work is you see very little news because you're in early and you're home late.
Yeah, right. Yeah,
You're not
yeah.
living it in the way that you are in the national system. So I would say the service the service needs to deliver what it's set out to deliver. We've got a lot riding on this, so let's not be distracted.
That's very clear. They got to focus. Just final one to end, Jim. It's amazing that I'm talking to you this morning, bearing that I'm a Spurs fan, and I know that you're a Newcastle fan. So thanks for that. Last night, look, it's no secret you love your native northeast. Obviously your life has got a fair slice of London life, being chief executive of NHS England. Will you still be CEO of NHS England this time next year, or will you be enjoying your season ticket up at St James's Park?
Yeah. So I'm still trying to avoid this stuff about when I'll go back local again at some point. I want to do that, but I also want to finish as much as I can what I've started here with colleagues as well. And with the systems work together has been brilliant. I've really enjoyed that. So I'll just avoid completely putting a date on it. But just to go back to last night, I got a message from a Spurs fan last night ridiculing Newcastle's strip, Steve, right at the start of the game. I thoroughly enjoyed ridiculing the result first thing this morning when I got up and read the message.
Well, it is
Fantastic.
beyond painful, especially since the other side of North London look like they're going to win just about everything, and we look like we're about to get relegated. So, happy days to end on. Listen, Jim, it's been a pleasure to have you on. Nice to see you. Good luck with the 10-year plan and the 10-year workforce plan, which is, of course, to come. They've got to dovetail together. You can get us Prevention is the New Cure podcast at gmail.com. You can find us on all the social media channels. And, please give us feedback on the interview. We've really enjoyed talking to Jim, haven't we, James? Very interesting.
We have indeed.
Insight.
Jim, you've been very generous. Thank you very much and good luck.
No, thank you both. Good to see you again.
God bless. This is the Health and Politics podcast. Prevention is the New Cure. Until next time, we'll see you then.